دكتور محمود عبد الكريم رود ماب تو ريفيجن ني.
كتير جدا. خلاص مش مهم. لازم. شكرا. السلام عليكم. الحقيقة أنا طبعا بتشرف بإني كل سنة ببقى مع حضراتكم وبالدعوة الكريمة من مستشفى الهلال، إخواتنا وحبايبنا، عشرة عمر كبيرة. وكنت شرفت إن دكتور محمد عوض ودكتور وليد طلبوا مني أعمل المحاضرة دي. دكتور وليد is very good negotiator. قلت له وليد there is no way on earth إنه واحد يقول الريفيجن كله في محاضرة واحدة. فالبارجن نفع، لقيته كلمني وقال لي you'll take 30 minutes to cover that. فأنا آسف إذا كنت هطول شوية، بس I'll try to cover the main important points. طبعا المحاضرة دي محتاجة كورس كامل. هي اسمها Roadmap to Revision Total Knee. I tried to make it like the 10 commandments of total knee. So I'm going to cover preoperative planning. Why did it fail? Diagnostic evaluation tools, role in revision total knee. Are there any stepwise approaches? And some tips and tricks. To start with, it's nowadays, even in Egypt, it's increasingly common procedure. So we have to develop a systematic way of thinking and stepwise approach for planning, executing the revision surgery. We need to plan every single step to avoid trouble, ensure the correct implants and inventory are available, having a plan B, C, D, and the list goes on. Step number 1, manage expectation. Unfortunately, those patients are really usually not very satisfied, because for them, needing revision is a failed surgery, more arduous for the patient with lesser outcomes, and we need to exclude septic from aseptic. Usually, this lady comes to your clinic. I think all of us have seen this lady before, or a similar one, just having this facial expression. Well, doctor, I'm sorry to tell you, I'm worse now than before the surgery. The other one is, my knee still hurts. Another one, when you look on the x-ray preoperatively, you don't have a clue why this was taken to theater to have total knee, and sometimes we see that in Egypt, as I'm sure everyone has this experience. And now the chance of success in these patients are really very minimal. So we must understand what the problem is before you can fix it. No revision surgery should be attempted until accurate mechanical, unless septic obviously, explanation for the failure has been established, period. Revision for an inexplicably painful knee without explanation, will yield miserable results. Exploratory surgery in revision total knee is contraindicated. We must have a good chat with the patient regarding realistic expectations. Is there something that I can fix? The likelihood of improvement. And guess what? When the patient comes back with postoperative deformity or residual, it might improve compared to the pain, and stability compared to the stiffness. And beware, please, of single component exchange. It has very negligible percentage of success, so please stay away from it unless you are pretty sure that this could suffice this patient. The very famous paper about early failures in total knee arthroplasty, just to summarize, infection up to 38%, instability 27%, and then aseptic loosening in about 16%. So step 1, you need to get to know your patient, including history, current symptoms, previous procedures, change in function, limb appearance, instability, comorbidities, functional expectations, and also, which is not very easy in Egypt, try to get old op notes or try to ask what happened previously. The most important and the most cost-effective diagnostic tool, guess what? Proper history taking and some decent physical examination, which sometimes ignored, and we usually rush into the x-rays. And this would raise the red flags of some pathologies, including if the patient happened to have wound healing problems, wrong drainage, cellulites, lack of pain-free interval, then it might be infection. Startup pain, and whenever they say the first few steps hurt more than the next 10 steps, aseptic loosening, giving way catching, can't trust my knees, it's really unstable, instability, Knee and lower leg pain diffuse with prolonged walking with some vascular changes, then vascular disease. Thigh pain, radicular pain, numbness, spine or referred from hip pathology, and more than 50% of our patients referred with a painful total knee have spinal stenosis. So we have to think outside the box and consider every single painful knee might have another pathology or another source of pain. Examination, you need to examine the vascularity, neurological function, and obviously joints with S, because hip and spine above and joint below. So history and physical examination could be very cost-effective diagnostic tool, by which you can be able to diagnose provisionally infection, aseptic loosening, instability, vascular disease, spinal stenosis, in addition to hip pathology or CRPS. Step number 2. So we've done with step number 1, get to know your patient. Now, get to know the knee, extensor mechanism, range of movement, laxity by examination, asking for some radiographs just to evaluate the implant condition, whether it's loose or not, defects, and classify them, as I'm going to elaborate later on. Ask for CT scan, it's very helpful in these cases. Always rule out infection in every single case, even if you don't have red flag for infection, including CBC, differential CRP, inflammatory markers, and some aspirate, white blood cell count, percentage of polymorphonuclear leukocytes, culture and sensitivity, and if you happen to have the alpha defensin or the leukocyte esterase, which is quite cheap and available. What about bone deficiency? Sometimes the preoperative assessment is quite difficult. You need to review the x-rays properly in addition to CT scan. Just locate it, whether in the tibia, femur, both, contain peripheral combined epiphysis, like less than 1 centimeter, metaphysis up to 5 centimeter, or diaphysis more than 5 centimeter. The very famous and still in use Aury classification, Anderson Orthopedic Research Institute, divides it into type 1, intact metaphyseal bone, so it wouldn't compromise the stability of a revision prosthesis. Type 2, there is some damage to the metaphyseal bone, and defects can occur in one femoral or tibial condyle, they call it 2A, or both condyles or plateaus, and they call it 2B. 3, here, that's the difficult one, where you find deficient metaphyseal bone, which compromises a major portion of either condyle or plateau. The other more recently dealt with in the last decade or more, actually, the zonal fixation revision total knee arthroplasty. It's a simple, reproducible framework for planning your revision, assessing the femoral and tibial bone stock for fixation. Zone 1, this is the epiphysis, or the joint surface. Zone 2, metaphysis. Zone 3, diaphysis. We must gain fixation in at least 2 zones as they recommend. For proper preoperative planning, we have to take on balance what is the condition of the soft tissues, in addition to what sort of fixation based on the bone loss, as well as the constraint required. So regarding the soft tissue, it would have a great impact on our skin incision approach for access, and also if the patient would happen to have laxity, then this would determine the constraint required. Fixation required for bone loss and constraint, and also you must have some augments, sleeves, or cones. And the constraints, again, affecting the soft tissue condition or affected by the soft tissue condition as well as the bone loss. Starting with step 3. So till now, you know your patient and you know the knee. Step 3, skin incision. We usually say use the most lateral, as the vascularity basically comes from the medial aspect, versus the most appropriate. If we do need to cross the incision, please, it should be not less than 90. Avoid acute angles less than 60. Wide skin bridges more than 6 centimeters or even more if you can. Speak to your plastic surgeon and consider the need for flap in some difficult cases. Step 4. The key to success in revision total knee arthroplasty is safe surgical approach using exposure that minimizes complications. So that's very, very important, as reported in this paper. And guess what? In most patients, actually a medial parapatellar arthrotomy, which we all very familiar with, but with complete synovectomy might prove itself sufficient. So for exposure, avoid subcutaneous dissection, full thickness flaps, arthrotomy, medial parapatellar with large medial release. You need to do complete synovectomy anterior to reestablish and clear the gutters, release all soft tissues adhesions, externally rotate and deliver the tibia appropriately, expose the medial tibia to the mid-coronal point, and also release the posterolateral corner of the tibia. So please, in the revision surgery, no place for small incision or small exposures. You might even need to peel the soft tissue scar lateral to the patella and do lateral release if necessary. Sometimes you need to slide the patella laterally. I like to evert the patella. Others might not like to evert the patella at all when it comes to the revision. I like to operate in a better condition, and the exposure would allow me to tackle every single problem as I can plan. But not everting the patella provisionally would be great in all hands, because this would avoid the strain on the quad. So till I release, expose and remove my prosthesis, and then I might be able to evert the patella. What about extensile exposures, including quad snip, TTO, femoral peel? And the purpose of all these extensile exposures is basically to avoid extensor mechanism disruption, in addition to having proper exposure to deal with the problem. What about the rectus snip? As you can see here, it's basically oblique apical extension of arthrotomy across the tendon. It proved itself actually adequate in most cases, at least 5 centimeters from the superior pole of the patella, from 5 to 8 centimeters max. No need to alter post-operative protocol, with good outcomes, actually. What about TTO? Sometimes it's the working horse. It's required not as commonly as the quad snip. However, the more complex, the more difficult the cases, it starts to be the working horse in my hands. So for fully cemented stems, to get them out, it's 5 to 8 centimeters in length, taper proximal to distal, 10 millimeter proximally to 5 millimeter distally, using oscillating saw followed by osteotome, lever open and try to leave it, to leave the soft tissue attachment laterally, just to just maintain the vascularity, and you can repair it with wires, screws or cables, according to whatever you like and according to the size of the fragment. There is also what's called quad turn down, Cones-Adams. Again, it's rarely indicated. Extension lag instance is very high, so please just forget about that. In some really complex cases, you might need to do tumor prosthesis or modular, where you got to do what we call femoral peel, subperiosteal dissection of medial lateral MCL, LCL origins removed, posterior capsular removed. You have to be careful of devascularization of the distal femur proximal to where you are going to put your prosthesis. Step 5, implant removal process. Actually, most of us, whenever we plan revision surgery, we look how are we going to revise that. But we never concentrate, most of us, I should not generalize, we never concentrate and actually sometimes overlook the implant removal process, which is actually more important or as important. It has to be very safe, very careful while doing it, should be bone preserving, because basically it can jeopardize the reconstruction, and we should be well aware and respectful of the extensor mechanism and tibial tubercle. Again, you try to do that in a stepwise approach, creating space without injury to other ligamentous structures. So I start with the polyethylene insert, then the femoral component, then the tibial component, and finally the patella. The first golden rule for this step, no role for many invasive techniques. Proper synovectomy, complete one. Exposure to the prosthesis cement bone interface would prevent intraoperative fracture and preventing soft tissue damage. There are quite a few tools, including hands, power instruments, ultrasonic, or implant-specific instruments. Starting with the osteotomes, they are quite handy, but you need to work with them on the implant cement interface rather than the bone interface. Careful not to crush osteoporotic bone, and you can wedge one of them, put the first one, and then double stack, stacking against the widest part of the bone. What else? Jiggly saws, I hate them. Be careful. Whenever you can't do with the power saw, you can use them, but they can migrate, so be careful, please, and can break. Punches, they are useful to disimpact well-fixed prostheses. Power saws, I love them. not only for the cementless, but also for the cemented components. I love the power saw, the mini saw from the foot set. I always ask for these kind of small saws. In addition to if you have power burrs, small drills, or metal cutting instruments. Unfortunately, we don't have a lot of them in Egypt, in addition to ultrasonic instruments, if you happen to have some of them. There are different tips and tricks, like double stacking, osteotomes, or also making a small hole beneath the tibial base plate, and then impacting using one of the punches and impact it from inside. Also, I came across this nice technique of doing like not tibial tubercle, it's distal femoral osteotomy, which is the counterpart or just analogous to the tibial tubercle osteotomy. The main important thing and take-home message out of implant removal is patience. This is the key for success, okay? Step 6, that's the most important part of the lecture, guys, by the way. The goal of revision surgery is basically to turn a complex revision into a primary. This is the most important, so for those who might not have been concentrating, please just bear with me in the coming few minutes. The prerequisite for revision surgery to understand the gap balancing issues, principles, and always take on balance that the flexion gap is always bigger than you think. Usually you have the problem with the flexion gap. I came across this schematic 3-step revision, which I apply in my practice since my training in UK 2 decades ago, nearly. So the step number 1 is establish the tibial platform. Step number 2, stabilize the knee in flexion. Step number 3 is stabilize knee in extension. So tibia, flexion, extension, done. Right, let's elaborate. Why we start with the tibia? Because basically it's the reference or the platform which is common to both flexion and extension gaps, as we heard in the excellent preceding lecture from Dr. Mahran. This is the foundation from which an arthroplasty can be recreated. There are no implications at this stage regarding the joint line. So don't worry, till now, you are not going to decide on the joint line because this is basically depending upon the femoral component size and position. It's merely like a stable surface formed by the tibial base plate and the diaphyseal engaging press-fit stem. So again, by putting this diaphyseal fitting stem, this is not necessarily that you are going to end up with. You might change the plan and put cemented or even hybrid, which is now more common nowadays. So it's just to fix things, this tibial plateau base plate temporarily, while the big picture of component size and position is established. As the tibia happens to be asymmetric bone in some patient, most patients, some type of offset stem is required in the revision. And by this step, by just doing this step, establishing the tibial platform, the tibial component rotation, the AP position, and the slope will be established. How the workflow inside the operation will work. First, you prepare the tibial canal by to determine the stem diameter by just streaming intramedullary, deciding on the press-fit diameter and the length of the stem. And you only allow yourself to cut very minimally and be conservative with your cuts. And then you can determine whether you need some sort of augmentation or let it be metaphyseal or whatever. And then you size the tibia, the tibial base plate, and then you ask yourself, do I need some augmentation and probably an offset stems? I think you are going to have a great, excellent workshop this afternoon from our dear Professor Professor Dr. Ahmed Abdelaziz. Now prepare yourself for and assemble the trial with the offset stem. So we've done with the first step. Second step, to stabilize the knee in flexion, not extension. And it divides actually into 3 main parts. Femoral component rotation, femoral component size, and joint line. Size, rotation, size, and joint line. What about the rotation? Here, the white side line is gone, most probably. So the only remaining landmark, or one of the very important landmarks, is the transepicondylar axis. And try yourself to cut at right angles to that, just to respect the rotation and to restore the proper rotation. In addition, if your tibial cut, you can also be parallel to that if it was perfect cut. The second thing, the component size, and actually the size, and to a lesser extent, the anteroposterior, whether you are going to anteriorize or posteriorize the position of the femoral component, would dictate the restoration of the tension to the collaterals. And we usually like, in the revisions, in these cases, to use the largest femoral component. How to decide on that? If you can look on the figure, you can get one of the trials and just measure the mediolateral diameter, or the mediolateral dimension, of the distal femur. Try to avoid overhang by all means. This is quite inappropriate. Evaluate the relationship of the joint line. We know there are different landmarks, but they usually advise to compare that to be within 1 centimeter distal to the patellar pole, inferior pole, provided that the patellar tendon is intact. Okay? 2C, then after doing both, we need to decide in the joint line. There are two different scenarios. Whether you say to yourself, I'm going to use large femoral component, thicker posterior augment, just to fill the flexion gap, then you need to, here, you only need a thin polyethylene. So large femoral component, thick posterior augment, and thin polyethylene. Now, the joint line would be perfect or better because it's distal to the distal pole of patella within 1 centimeter. The other scenario is, you might say, well, I'm going to take small femoral component, thinner posterior augment, and thicker polyethylene insert. Now, here you are going to elevate the joint line. Be careful of that. This is less desirable in terms of the outcomes of the patient and the mechanics of the total knee. 3, we need to stabilize the knee in extension. And guess what? By just extending the patient knee, you'll do that. The caveat here, if you need to use one of the stems, which can slide proximally or distally, and by just extending the knee of the patient, you can create the extension space, which is equalizing the flexion space. So actually, it occurs kinematically. And I tried since my training in UK, they tried to teach me this way just to make it very simple. Again, it might not be suitable for every single case, but for the most cases, it will be very handy. This technique requires the physical engaging press-fit trial stems to hold the trial components in place and determine the need for augments. Okay? The workflow, so I start by reaming the canal, the intramedullary reaming of the femoral canal to determine the stem diameter, as I've just done with the tibia, length to engage the diaphysis if it's press-fit, cut the distal femur to freshen the bone, very conservative cuts, not more than 2 millimeter, then determine the joint line, then you size the femur, again, paying due care to opt for the largest femoral component, especially mediolateral dimension. And then you need to determine your femoral rotation here based on what we call the transepicondylar axis. And then you determine the level of constraint based on balancing, and then voila, you can implant the components. Let me remind you the joint line levels for all our junior trainees who might be with us. They usually say, again, on average, because there is standard deviation, 30 millimeter or 3 centimeter distal to the medial epicondyle, 2.5 centimeter distal to the lateral epicondyle, and 1 finger breadth, or in fact 1 centimeter below the inferior pole of patella. Some might choose also the head of the fibula, like 1.5 centimeter, 2 centimeter, but again, this is not very, it's quite variable. You can also compare it to the contralateral side and review the x-rays. Measure intraoperatively. Sometimes they say just measure the femoral width, mediofemoral width, and then 1/3 of it, this is the distance of the joint line should be from the medial femoral epicondyle. And you can always do trialing and see where it goes. And this is very important. So here you need to measure the extension and flexion gap and get them both equal, and also getting the joint line, as we just mentioned many times, in a proper way. And guess what? Then you will be able to have a stable knee by just equalizing the flexion extension gap, because any instability, this means the difference between flexion and extension gap. And then you detect the bone quality. Again, like in the tibia, you might find yourself needing offset stem, and then you decide on that. Again, let me reiterate that one of the commonest balancing scenarios, we usually like to use the largest femoral component based on the mediolateral dimension. Usually, we like to use distal augments so as to decrease the extension gap and normalize the joint line. And also, just to decrease the flexion gap, we need to use posterior augments. So most of the revisions would require using posterior augments as well as distal augment for the femoral component. And then after doing all that, you proceed with just preparing your box, deciding on the how are you going, which constraint are you going to choose as well. Now, for the zonal intraoperative analysis, if you happen to have bone loss, which is pretty much encountered in most, if not all, revision total knee, again, back to the zonal classification. So for zone 1, prepare yourself that you might just need cement with screws. This used to be done in the past. Bone grafts and also augments. What about zone 2? Again, bone graft, cones, or sleeves. What about zone 3? Again, you might need to, in addition to the previously mentioned, then you need to use some of the stems uncemented, cemented, press fit or hybrid, which are rising nowadays and commonly used in practice. Again, you'll come across different algorithms of how to deal with bone defects and revision total knee. It requires a specific course actually, or a specific lecture on its own, but I just wanted to summarize the main things. One of the attendees asked me, could you please elaborate the difference between the cones and sleeves? The difference is we don't have sleeves in Egypt, so thankfully we have cones. But again, just to reassure you, there are some differences in the designs. One is linked to the prosthesis, one is modular, but linked to that, united to that through the cement. But some study shows that there is no significant difference between both, and we have currently in Egypt just the cones. Step number 8, you are going to decide on the stem. As we mentioned previously, both on the femur and the tibia, you are going to ream the intramedullary canal, and then put the measure, you need to measure and make sure that you need offset stem, or just if it was the 0, the tool for that, you can measure whether you need 2, 3, 4, and then you recreate that just for the best coverage of the tibial base plate as well as the femur, the distal femur as well. You dial this tool, and then it tells you what is the best angle or what is the best figure just to assemble your offset stem at the end. Step number 9, the constraints. After doing all that, well, it divides. They usually advise, please try to use the least constraint, starting with the cruciate retaining. To be honest, I don't think they have major role in the revision arthroplasty, especially for the cases we encounter in Egypt. Posterior stabilized again, but sometimes you might just need to use them, including whenever you have intact collaterals, balance, flexion, extension gaps. Whereas valgus constraint, they are among the working horse, including single collateral grade 2 laxity, balance, flexion, extension gaps. Rotating hinge, I think we need to use them in quite a few cases whenever we have bicollateral insufficiency, gross flexion extension imbalance, and we need to consider in extensor mechanism attrition and neuromuscular recurvatum, and also in addition to the fixed hinge. Step number 10, before you go and say, well, the job is perfectly done, you need to ask yourself, did I protect enough my closure, including the extensor mechanism? But more importantly, did I solve the issues? And always ask your assistants and get a surgeon from the room next to you. Ask him, what do you think about that? I've done so and so and so and so. And then pay due care to the post-operative protocol, including timely mobilization of your patient, weight bearing with physiotherapy according to the plan, and according whether you use some augmentation or bone graft or whatever. Make sure that early goals are met. This is very important. Even some might say, don't discharge the patient till you are sure about that. I mean, like a couple of days or so, you might need to take the patient back to theater. I hope not to have this situation. Anticoagulation versus wound complications, vigilance, and early intervention in case of wound problems, just to manage early infection as early as possible. So coming now to end my talk and the take-home message, let me repeat the 10 steps. You need to know your patient. You need to know the knee of your patient, the skin incisions. Which approach are you going to choose, whether extensile or just standard medial parapatellar? The removal, be patient while you are removing the implants. stepwise gaps balancing and the joint line leveling, as I just mentioned, the zonal fixation classification and what sort of augments or cones or sleeves, the stem, including the offset stem, what kind of constraint you are going to choose, in addition to the postoperative regimen. So let me conclude. Accurate diagnosis of the cause of failure of total knee must be known before taking your patient to theater. Careful and comprehensive preoperative planning. Start with the tibia to build a solid tibial base on it. Conservative cuts, please. Complete array of revision components and augmentation tools should be available. Stems are needed, including offset stems. Start with the tibial platform, then flexion, then extension, as we just mentioned. Reestablish the joint line. Achieve a symmetric flexion extension gap. Be thoughtful, well-prepared, focused. An organized approach is essential, otherwise the reconstruction is doomed to failure. Thank you so much.
يعني هل في أسئلة ولا هنبروسيد؟
بنشكر طبعا الاستاذ الدكتور محمد عبد الكريم على المحاضره الشيقه دي. ودلوقتي
احنا عندنا البانل اللي جايه، دكتور ابراهيم بدران، عندنا البانل اللي جايه للكلينيكال كيسز، فبنشكر حضرتك والدكتور احمد مره والدكتور احمد سامي، والبانل بتاع كلينيكال كيسز تشرفنا، دكتور الجنزوري ودكتور رضوان، ومين تاني معنا؟ الدكتور احمد عبال موجود اوريدي فوق، دكتور وليد عمرو.
السلام عليكم ورحمة الله.
هو دكتور ابراهيم جادو موجود ولا مش موجود؟ طب لو تشرفنا يا دكتور ابراهيم بعد اذنك. معلش احنا هنقطع حديثك يعني.
هنبتدي ان شاء الله السيشن دي البانل ديسكشن. استاذ الدكتور احمد عبد العال، توتال ني ريبليسمنت، في كيس كده من الحاجات اللي احنا متعودين عليها. اتفضل يا بيه.
شكرا. السلام عليكم. كل الشكر لمستشفى الهلال والدكتور محمد عوض على الدعوة الكريمة. توتال ني ريبليسمنت ان ستيف نيز، ويبقى في الحالة دي the main goal او الحاجة الأساسية اللي عايزها المريض انه to regain movement in the knee. في الإنسان الطبيعي عشان البني آدم يتحرك normal walking محتاج from 70 to 80 degrees of knee range of motion.